And, the next step with a lot of this research is thinking more of what we might call clinical epidemiology, which is how do you take this population-based data and turn it into individual level risk factors and actually create algorithms to say that this person truly is now at this level of high risk for something and you need to do something, or these are cut points where you need to triage them into different areas. And
so where are we as a profession in that?
Well, I think we're actually I think we're pretty nascent in that area. I think there's a lot of really great audiologists out there, and I think most of the time we mean well, but a lot of times we throw the whole test battery at people, for example. And I think when we start to think more about almost like precision audiology, so using clinical epidemiology to inform precision audiology, we are going to get closer to picking and choosing our test batteries based off of clinically set cut points based in the data, right? And I think audiology, I'm not saying it's, at the, it's behind or anything. I think a lot of fields are like this, where we're just getting to this nascent stage of now we're being informed by data, and we're doing a better job of taking that population data and starting to figure out attributable risk within an individual. And if you really wanted to dig into this kind of literature, I would always say, go look at the cardiology literature, because they always seem to be 20 years ahead of the rest of.
Kind of makes sense, right?
Yeah.
Well, it's good to know that. I wanted to put a plug in for you were the guest editor for this. I don't know if people can see that very well. This last issue, or maybe not the first issue this year of Seminars in Hearing, right? This is a great, if anybody wants to know more about the relationship between audiology and public health, I would have you take a look at that. But there's one study in there that I wanted you to maybe speak about a little bit. It wasn't by you, it was maybe by some researchers in Michigan that looked at preventative care. And I thought this was really interesting. People that had hearing loss were more likely to not do the things they needed with respect to preventative care. So I think,
is this Nicholas Fioravantes?
Yes, I think so.
So Nick is fantastic. He's a med student at University of Maryland, and he worked with Lama Asi, who is my former mentee. Now she did her MPH with me, and now she's at University of LSU New Orleans, and she's an ophthalmology resident, actually. And Lama's done a few studies in this. There's actually a relatively large follow-up study to this that I think your audience might be interested, coming out in American Journal of Preventative Medicine, where we look at something very similar, except on a much, much larger scale. So the long and the short of it is exactly what you said. Adults with sensory loss hearing loss in this case, are less likely to engage in preventative care activities. And those are screenings. In the other study, we looked at things like vaccinations. Screenings are, across the board. I think the big one, though, in this study, and I might be mixing up the studies, this one might have been mammograms. And we've also done sort of heart attack knowledge, which is a big thing that's been measured out there among the public. And what we believe is happening is we're looking at the other literature that we've done, where we've seen associations between hearing loss and various healthcare utilization outcomes. And, you don't just get from one to the other via just communication, right? There's a lot going on in this pathway. And so in this particular pathway, what we think is going on is hearing loss potentially leading to poor communication with patients and providers. And those barriers change your actual utilization of these, preventative measures, these healthy interactions with the healthcare system. And it's twofold. We don't just think that, people with hearing loss are doing a bad job of reporting things. We actually think that when you have poor communication, the physicians may not be doing as much as they should be doing, because they're potentially becoming, frustrated, and they're not, moving as quick. And, these levels of frustrations are two ways. And then maybe two, they just, don't get to it. And so our theory is actually that it's not just pure access. It's not just that you have trouble calling or something like that, or getting through on the system. It is a lot of just, when you have those conversations, you may end up not getting to the next level, and maybe the phissician not even recommending it because of the communication breakdowns.
That's really interesting.
Yeah, sorry. Go ahead, Brian.
No, I just, just the value of early intervention with people that need help with hearing. I think we take it for granted when we have good hearing, that it's easy for those that don't hear very well to just kind of tune out easily, and we don't do as much as we can to help them.
Exactly. Like, again, this is this ageism in society where you have an older adult and they have hearing loss, and, they start saying, huh, and what, and you're so likely to almost I say you as in like the societal level, like we as a society are so likely to start to ignore them and sort of not think as much about their needs. And maybe, again, in this case, from a healthcare standpoint, not push them to various preventative measures. And vaccines are the big ones for us, screening as well. But, and I'm not even talking about just like, COVID vaccines, but just in general, this is something that, an appointment, a doctor, a physician really has to push that and get that set up. Right. And to see it not happening at the same clip as those without hearing loss, and, this is after accounting in the population then for, vaccine hesitancy, which we have no reason to believe one would be higher than the other in these groups. This is an important area. I think that we discount hearing loss among communication. I know this sounds crazy to audiologists, but if you actually dig in on the literature, there's a whole literature on patient-provider communication, and hearing loss is almost never mentioned. And it's wild to me. And I really do mean it's like wild. Like I can't wrap my head around it that people say this. And I tell this story from a few years ago. I have this paper published now in Health Affairs. It's just published this past May, and it's on unmet healthcare needs among adults with hearing loss. And the first time I submitted it to a different journal, it was rejected from another journal. Health Affairs is a very good journal, ended up in a better journal in the end. But one of the reviews that came back was, this person keeps mentioning communication, but they're not measuring communication at all. Like hearing loss is not communication. And I almost spit out my coffee. I was like, what are you talking about? Hearing loss is literally a fundamental technical barrier to orally presented communication. I know that verbal communication includes written and oral, but we know that the vast majority of communication that occurs in this country is oral, and we need to ensure access to it. And whether that is ensuring that there's written access to, that's a different story. But the point for me is that it's fundamental to communication. And, for someone to disregard it like that, I just
for granted. That's crazy.
Couldn't believe it.
Well, there's a couple other things I wanted to talk about with some of the work that you've done there. One is the acronym is ACHIEVE. And I know this in our profession, this has gotten a lot of traction over the last few years. I know this is a longitudinal study. So maybe you could update our viewers on what you're looking at in the ACHIEVE study and what we can look forward to when it's published.
Yeah, I think so. The ACHIEVE study is a large randomized control trial of best practice hearing care on cognitive decline among adults with mild and moderate hearing loss. And so it's about 1,000 individuals, half randomized to hearing care, half randomized to sort of a healthy aging equivalent. They essentially sit down with a nurse and discuss various issues of healthy aging. I think this is very much the culmination of Frank's, entire career to this point, to a certain point. I mean, it's not to use too much hyperbole, but it really is one of these studies that I don't think will ever get redone at the same level. You're going to have a hard time convincing the NIH or other funding agencies to give you that much money to actually do this study again. So I do think it's sort of a once in a lifetime study that we're seeing right now. And at this point, we are done recruitment. We've been done recruitment for a while. It's a 3-year study. So individuals, they're randomized to their intervention, and then we follow them for 3 years. And we're looking at cognitive decline from baseline to 3 years. And we have individuals at this point who are coming in for their 3 years. And so, we're getting closer and closer to the wrap up of this study, which will probably be in 2023. And then we'll have hopefully, as far as evidence goes, this is pretty much the definitive answer on the protective effect of hearing aids. And, it's important, again, that our field, audiologists, we understand public health literature because, we go back to thinking about interpreting studies, but also just understanding the basics where just because you find an association between X and Y does not mean that getting rid of X or addressing X is actually going to fix this necessarily, right? So what that means is, just because we found that hearing loss, has this, what we propose as a causal association with cognitive decline, did not mean in any sense that hearing aids would then change that. And this goes for all fields. Like, you find an association between hypertension and dementia. It does not mean reducing hypertension necessarily would reduce dementia. I mean, it does, but, that didn't mean that definitively. So now this is how we answer that question with a
right. No, that's why it's so important. Right. I'll tell you, as a little bit of a sidebar here, I refer to there's the clinical protocol that's used in the study. The lead author is Sanchez. I don't remember her first name.
Yeah. So I always say Vicky Sanchez, Michelle Arnold, and Terry Chisholm are the the group we partnered with at University of South Florida to develop the intervention.
Yeah, and then in about a year or maybe a year ago, it was published in Ear and Hearing. And so when people ask me about what's a good clinical protocol that I can use to make sure that I'm on the forefront with respect to how I practice, I always say, do what they did in the Achieve study, because that's very rigorous and cutting edge, and you're not going to go wrong if you just adapt that into your own clinic. So,
oh, she'll appreciate that.
Anyway, the last thing about all of your work in this area I wanted to touch on was, and maybe this is another example of the dosage effect, but it has to do with expenses or expenditures. I think it was a couple of years ago, you published in one of the non-audiology journals, over time, how much a person with hearing loss costs the system relative to somebody of a similar age that has normal hearing. Could you maybe talk a little bit about that?
Yeah. So in that study, we used a large clinical database, essentially Optum Labs database. So it's a claims analysis. And what we did was, we matched individuals with likely hearing loss to those without likely hearing loss. And I say that because we used claims to find this. And so we very much looked for age-related hearing loss. This was a long process. I won't bore you with it, but we think that we had developed an algorithm that was probably highly specific, but probably low sensitivity. And what I mean by that is if we found somebody, very likely they had age-related hearing loss. It's very unlikely that it was something like, Meniere's or some other or some ear disease that was miscoded or something like that. But we know we did not get all the hearing loss. So this will come up in a second when we interpret this, actually. I'll jump right to the 10-year conclusions. We did 2-year, 5-year, and 10-year looks because you can get a lot more people in a 2-year analysis just because it's hard to get continuous claims on somebody. But in the 10-year analysis, we have 2,300 individuals with hearing loss, 2,300 without. We matched them on everything under the sun you can think of, including their baseline utilization metrics. So these are as close to the same individuals with and without hearing loss as we can get. And then over a 10-year period, those with hearing loss incur on average $22,000 more in healthcare expenditures. And it's very much not due to some hearing loss expenditure. There's just nothing in there barely. And we excluded hearing aid use. But when you actually, and we also found, the other things that people I think are intrigued here is higher rate of hospitalization, 46% higher risk of a 30-day readmission, longer length of stay, more likely to have an ED visit. What's important when you interpret that too, again, the importance of getting the fundamentals of public health. When we have that high specific, relatively low sensitivity identifier like that, that means that there's people with hearing loss also in the control group. And if we think that the association is that hearing loss is what's driving it, then that is actually a conservative bias. So in reality, the difference might be much bigger if we had a better exposure where we were actually able to really, truly identify hearing loss.
Right, makes sense.
So it's a relatively conservative estimate. And I think that's what the most important thing actually that people gloss over in that study is adults with hearing loss are incurring much more healthcare expenditures. And I don't interpret it necessarily as a hit to the system. I think it's unfair to the individuals. I think the individuals are getting bad healthcare to a certain extent because the system is not accommodating their needs. Right. And it's a justice issue in the end to a certain extent. It makes sense.
Which leads me to the last thing I wanted to talk about with you. I would think that insurance companies, government policymakers would pay attention to numbers like that. So can you share with us sort of at the policy level? I know there's a lot of talk right now about maybe Medicare being expanded. How does your research fit into some of these changes that we might anticipate in policy?
Yeah, that's a great question. I think the work of the center fits in 2 levels. One, I think that we have helped to inform the conversation and show them these kind of numbers and show them the potential cost benefit of, addressing hearing loss. The problem though is that the CBO, the Congressional Budget Office, cannot assume that. So we don't have, until the Achieve trial comes out, we don't have strong, rigorous evidence saying that hearing aids actually reduce costs. So instead, we're left with the assumption that, perhaps if you did something, it would, but it doesn't actually translate to anything in the financial estimates. The second part of this is our team, led by Amber Willink, myself and Frank Lynn are the 3 who really do this work. We think a lot about what a Medicare policy might look like and trying to find a sweet middle ground to a certain extent. And what I mean by that is the Medicare it's very unappealing for Medicare to say, we're going to cover hearing aids and hearing care services for everyone with hearing loss, because that is, as you know, when we break down those numbers, you're looking at like 20 million, 25 million Medicare beneficiaries. And that's using a conservative estimate of hearing loss, not even including unilateral losses. Mm-hmm. And that number is astronomical. And so you saw this play out in the last Congress, where they had the Medicare Hearing Aid Act now from Lucy McBath and from Georgia. And that was pulled into the Elijah Cummings H.R. 3. And the idea there was we would cover hearing care services for everyone, and hearing aids specifically would be for those with severe or greater hearing loss, is what was in there. And I think this plays into a nice, again, finding that middle ground where they're acknowledging the Over-the-Counter Hearing Aid Act technically covers the mild and moderate group. And they're also acknowledging that not everyone in that group gets hearing aids. The uptake of hearing aids in the mild group is really low. We're looking at like less than 5%.
Right.
And they sort of acknowledge that and say, let's take those numbers out of the equation then from population level because they have to assume everyone's going to get hearing aids if they, cover them, right? That the algorithms, it blows the congressional budget estimates out of the water. But then if you only address, more severe hearing loss who are not covered under the OTC Hearing Aid Act, then you're covering devices for them. But then I think a key aspect of this is everybody gets services. And this is something that our team wrote about. I wrote a JAMA article several years ago that was the foundation for this. And you may have actually seen too, Frank Lin just he sort of took those points and put them into another article in Stat News. But we established this early on that we think the fundamental piece here is don't worry about devices as much, right? Cover devices for the higher degree of hearing loss group because they're not covered under the OTC side. But perhaps the market is going to shift the way we deliver hearing care, the accessibility of devices. Let that cover on one side, and it gives people some skin in the game too. They've done something. But cover the services, cover audiology services, cover hearing aid dispenser services. That if we as a field really want to move forward and we believe we matter, then that's what matters. And that's the hill that we can die on. You've written about this before. It's the same thing as the unbundling conversation. When you unbundle, you show your own value. And I think that at a public health level, we've moved Medicare just enough to get them to see the value of the services, that's what they're focusing now in on these bills. And we'll see what the next version looks like. We don't have a bill actually right now. There's the MASA bill, but that's a different thing than Medicare actually covering hearing aids really. But we do know that there's a lot of discussion going on because in the proposed budget, coverage of dental, vision, and hearing care is in there. And the estimates are all based off HR 3, Elijah Cummings Act, but we'll see what it really looks like. I think there are some important questions out there right now. I think that there's questions around where hearing instrument specialists versus audiologists get linked up and put under Medicare. And I'll say up front for your audience that you cannot exclude one side at all. We don't have enough people to go around to service everyone.
Right.
It's a urban versus rural issue too, a serious issue. And then there's these issues of DME versus prosthetic, which is getting in the weeds a little bit, but essentially the idea that is it all custom or can we bid as durable medical equipment to buy a bunch of hearing aids for Medicare at once? And then I think there's also sort of an issue I hear a lot about, and we discuss macro level, what does the hearing aid look like? Is it top of the line, or are we giving people the option to upgrade out of Medicare? And that turns Medicare from covering a hearing aid to actually covering an allowance. And does Medicare want to go down that path? And are there really examples of us to follow in that? And I don't really see that in Medicare too much. There's Medicare Advantage, obviously, which is sort of an upgrade. That's a different thing. If people want to do Medicare Advantage and get different hearing aids, and that's the way this evolves, totally different. But Medicare itself, doing an allowance and then giving people essentially vouchers doesn't really exist.
Yeah, as I say, not in this country. I know in other parts of the world they have a system like that, but not here. No, it's good information. So I've taken too much of your time, and I really appreciate all this great conversation. Just maybe in closing, if you could share with us, what are some things like a take-home message for clinicians based on all of the work that you and your team have done at Johns Hopkins?
Oh man,
it's a big question, I know.
Yeah, I guess honestly, I would leave it as more of for clinicians, I would encourage people to start to search into public health for thinking about how they can improve themselves from a career standpoint. And what I mean by that is, read not just these pieces and just take away that, hearing loss causes X, Y, and Z, but, in that Seminars in Hearing issue, read Jennifer Deal's article on how to interpret epidemiologic studies. Start to look into things like implementation science and health behavior and society. And I think that if we can start to break down our silo in audiology and become more cross-disciplinary, we can move our field much, much further. And there are a lot of leaders out there doing this right now. I very much like the current, AAA president or incoming president, Sarah Sidowski, who, has gone out and got an MBA, and she's versed herself more on like this economic side of business side. And that's the kind of leadership that audiology has to do. And I'm not saying everybody has to go get a master's in public health or an MBA, but becoming more public health literate, I think, could really, really help push our field further. That would,
no doubt
if I can give a take-home message, that's it.
Yeah, no. I mean, I think our field, if I could speak about it, I think, and just thinking from the device standpoint, we're pretty good at like innovation and breakthroughs, but we're not so good at like follow up. You know what I mean? Like seeing people back, doing the simple things right. We don't really do that very well as a profession sometimes. And so getting insight from individuals like yourself is really helpful, looking at the big picture. So anyway, Nick, I can't say enough, thank you for being with us. All the great work that you and your group have done. Keep it up. We want to see more of it.
Thank you. Thanks. No, it's phenomenal to sit down and talk. Always good to see you personally, but I'm also
likewise. Hopefully next time in person.
Yeah.
We'll take care, and we'll catch up some more down the road. And
thank you
for our viewers. Bye.